So, hey, this is Anthony Davis with Health or Hoax. I'm joined here by Blake Loxterkamp and Dan Brown. We are all students, chiropractic students at Northwestern Health Sciences University. And this is a bit of an experiment for our Health or Hoax project. So we're going to we've each picked a meta-analysis or some kind of guideline or review on the topic of exercise for older populations. There's probably a lot of myths surrounding whether or not it's safe to exercise, et cetera. So we wanted to maybe put to bed some of those myths and hopefully encourage some more activity in older populations. So say hi, everybody.
Hello.
And maybe your name.
I guess I'm Dan Brown.
I'm Blake Loxterkamp.
Cool. So this is gonna be good. We're gonna just do a quick summary of each of the papers that each of us read, and then we'll just kind of have an open discussion. So this is a little bit informal, and this is a little bit of an experiment. So if you're watching this, bear with us, and guys, let's do the best we can here. So the paper that I read was called "Benefits of Exercise Benefits of Exercise in the Older Population." The first author on this one is Galloza, Galloza. This was not really a formal meta-analysis or review. This presented more like sort of like an evidence-based guidelines. So it was a summary basically of different styles of exercise, like aerobic exercise and resistance and strength training. There's a brief mention of like aquatic exercises, and then flexibility and stretching, and summaries of each of those. And stability and balance training. That's going to be really important, because I think a lot of people think that, let's go for the balance training so they don't fall. But there were some interesting findings in there that I kind of went against what I was expecting. The big takeaways from this review were, things that I already sort of knew and understand, but it was cool to walk away with some, hard statistics, some, concrete research to support it. Exercise is great for older adults. And that includes strength training. Obviously the aerobic exercise is going to be great because it's going to improve cardiovascular functions. But that strength training can, be important for, bone density, for balance, for fall prevention. So basically any, when you're looking at any type of exercise, this was a guideline for how you can go about implementing it with an older population. So rep schemes, how to progress through the exercise, where to start your exercise program, how many times per week and at what intensity, that kind of stuff. So this is a good, quick reference for somebody who's trying to guide an older person through exercise. But I mean, the biggest takeaway here was just that no matter what you're doing, it's probably a great thing and has incredible benefits for older population. So I can get into some of the quotes later, but let's hear what you guys read about first. So Dan Brown, what'd you read?
Yes, sir. So I read the paper titled "Strength Training in Older Adults: The Benefits for Osteoarthritis." The lead author on that is Nancy Latham. Basically, this was very similar to Anthony's paper. Is a little bit of an informal systematic review. They did do some statistics, but they do state in the paper that the statistics, there wasn't enough of the RCTs to do a proper meta-analysis in it, so there's some limitations there. But basically this paper looked at two questions in regards to osteoarthritis and strength training. One, does strength training actually increase strength, function, and reduce pain? And two, were there any changes in these functions compared to a general population, so comparing the OA groups to the general population groups? What was very interesting is that they used progressive resistance training for their protocol. They had about 8 RCTs, I think they chose. And within the RCTs, there was no one in the control group and the tested group that was under the age of 65. So they were very specific on making sure that they were older individuals. But what's really cool about their resistance training was that they made sure that the intensity ramped up with progressive training. So there was some studies that were, I think, 8 weeks up to 72 weeks that they followed. So it's quite impressive the amount of time that some of these did. But what they found in regards to their questions were that the general population, we'll start with the control group, really had a large effect size on increasing strength, specifically upwards to the 0.88%. And so they had a huge increase in strength, but when it comes to function and pain measurements, there was little to no change at all within those measurements. But what was very interesting about the osteoarthritis group that the paper pointed out is that even though strength was a moderate increase at 33% increase in strength, the function and reduction in pain was also moderate compared to nothing in the general population group. So function they measured just basically as the ability to move through a range of motion. And the fact that the general population with OA that don't have OA, they can move fairly well to begin with. But those with OA, the paper found interesting that the function increased just as much as the strength did. And the reduction in pain was on par at a moderate effect. Another thing that the paper looked at was that high versus low intensity didn't matter. The results were the same between high and low intensity movement. Some of the limitations, though, to this study was, and they stated this, is that they didn't look at hip OA or upper limb OA, so you can't generalize this to all of osteoarthritis. This is only for specifically knee osteoarthritis. So very interesting paper. But the conclusion was just make sure that even the oldest of the old can exercise and be fine doing it. So
cool. Blake, what'd you read?
So I read a paper called Age-Related Differences in the Dose-Response Relationship of Muscle Protein Synthesis to Resistance Exercise in Young and Old Men. And the lead author on that was Kumar. So the goal of their study was to compare the effects of exercise in young and old males on muscle protein synthesis. So they took 2 groups of 25 males. The mean age of the younger group was 24, and then the mean age of the older group was 70. And they controlled for BMI, so the average BMI was roughly the same. The methods were they split the 25 participants up into 5 groups and had each group do a different intensity. So ranging from 25% of a 1 rep max to 90% of a 1 rep max. And they had them do leg extensions and leg flexions on a machine. And I believe they had them use their dominant leg. So then they did a pre and a post muscle biopsy to measure muscle protein synthesis. So basically they took a large gauge needle and took a chunk of their vastus lateralis before and after. And they used some markers. Yeah,
for science.
It doesn't sound fun at all. They used some markers like phosphorylation P70S6K for like some sciencey things to kind of as like a rough marker for protein synthesis. So what they found is that protein synthesis in both groups was highest at a range of 70% to 90% of the 1 rep max, as opposed to those lower percentages. But the protein synthesis kind of plateaued after after that 60%. So you don't get any additional protein synthesis from like 90% 1RM versus a 60% 1RM. So that was interesting. And the other big finding was that the younger group had a higher protein synthesis response at about a 1 hour post exercise as compared to the older group. So their takeaway was that both groups would benefit from training in that 60+% range of their 1 rep max, but the younger group is going to have a greater protein synthesis response as opposed to the younger group, which I can talk about in a little bit, but I think has a lot of implications to how you'd program exercise, specifically resistance training for an older population.
Interesting. Yeah. That's interesting too, because it shines a light on how important it is to pay attention to study designs, because your study is, looking at some things slightly differently, or I should just say in a really specific way, where my review here I highlighted improvements in muscle quality after resistance exercise training when evaluated when you're evaluating increased motor unit recruitment and discharge rates have shown similar benefits in older adults to those seen in younger adults. So depending on what your outcome measure is, depending on what you're actually trying to pay attention to, you're saying that there was a little, a difference in the younger versus older, but, here I have highlighted that some other, more, a different specific measurement is kind of, the older folks see the same type of improvement. So it just reminds me to pay attention to what exactly is your outcome. So you can't just make blatant blanket statements about, oh, this is good for all of these people no matter what. Yeah. Okay, cool. So I'll go through and I'm just going to give the main highlights that I made from my article, and we'll just double back on all of our findings here. And at any point, I'd say, let's just have this kind of like an open conversation. I'm going to go through it from beginning to end and just give you, again, my yellow highlights only. And if you guys have questions, or it reminds you of something that's in one of your articles, or you want to compare and contrast, I'd say let's just go for it and freeform it. So I'd say it's okay if we make this a little conversational. So, all right. Introduction, essentially, look, oh man, 65 to 80% of their waking time, older adults, 65 to 80% of their waking time is spent sitting. And then it just goes on to list, like a million reasons why this is a bad thing. So, I think that some people are afraid of having old people, exercise, and that's ridiculous. And because then it just perpetuates this cycle of staying sedentary, and then it perpetuates all of these, things that we know that are really, really, that you can get out of exercise. You get none of those then, and then you get all of the consequences. So right off the bat, they're saying exercise programs in older adults should include aerobic, resistance, flexibility, and balance training. So if anybody out there is trying to say, well, it's okay for old folks to like get in a pool and do aquatic exercises because there's no weight on their bones, that's bullshit. We want older folks to be doing absolutely whatever they want. Now,
what was interesting, I'm going to interrupt here. My paper that they were stating that there's evidence that muscle weakness directly contributes to the development and progression of OA. And for those who have OA or know relatives that do have OA, that it is painful. It sucks sometimes. If you're sitting doing nothing, you can just sit there and it's just aggravating. So of course it makes complete sense that you want them to move. They're not fragile. There's nothing that I've read recently that says, oh, they're going to get minor fractures, right, while lifting a 25-pound kettlebell. No, like that. If anything, that's improving their
right.
function.
Mhm.
So you know what? I'm actually reminded. I'm going to call myself out. I'm going to throw myself under a bus here. So because I like to be a little bit of an example of that. If I throw everybody else under a bus, I should throw myself under a bus occasionally too. And I can remember in a video, in an educational video that I made about about the spine and biomechanics and overuse and stuff like that. I was just explaining Wolff's law, and Wolff's law is, seems pretty straightforward. This is the danger about learning a little bit about science and anatomy is you can take these little facts and be like, and just apply them to everything. And then you think you know what the fuck you're talking about, and you probably don't. So Wolff's law. All right. So it's like one of the first things you learn if you study any kind of biology or anatomy or whatever, exercise. And it's just that basically pressure on bones makes the bones grow more. So that could result in increased bone density, or it could result in, bone sort of like overgrowth. So we could, what I did, and this is where I was wrong, but I assumed that, if we disproportionately load the, anterior lateral surface of the disc, the vertebral body, then you're going to have and that's going to cause osteoarthritis because of the increased pressure, because Wolff's law, because increased pressure results in overgrowth of bone. Maybe that might be a thing that happens sometimes, right. But also, this is the thing that Craig Liebenson in the discussions he's been having recently, these free webinars he's been doing, amazing. He keeps bringing this up, which is that arthritis, we think that it's a condition of wear and tear. We think that arthritis is this condition of like you've overused your joints, but it's the exact opposite, that you get arthritis because you're underusing your joints. That if you look at the skeletons and x-rays of human beings throughout history, in times where human beings were more active, then they have fewer, basically less arthritis. And it makes sense too, to me, because a lot of we know that there are a bunch of different types of arthritis, and a lot of them some of them are autoimmune, right? And some of them, a lot of them are inflammatory in nature. So it's actually not necessarily due to Wolff's law that these bones are getting, huge. It's that you've got a systemic inflammatory condition. So exercise, we know, is going to help reduce all that stuff, and good diet and good, blah, 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 all these other things that might help with inflammation. But anyway.
Right. Good sidetrack.
Yeah. Okay. All right. So this is going to be a tangent. We're going to have a lot of tangents, aren't we? All right. Yeah, let's rein it in. All right. Cool. So I'll try to be brief here. So the first thing that it addressed, my paper, was aerobic or endurance exercises. There is high quality evidence that aerobic and endurance training of moderate to high intensity significantly improves the VO2 max in older adults. And the improvements that they observed were comparable to younger adults, except in older adults older than 75, there was a little bit less improvement. And some other stuff that it increases. Let's see. Aerobic and endurance training programs have well-established benefits for decreasing cardiovascular risk factors. And then there's just more details about which of those they are. But I mean, essentially, if we can reduce cardiovascular risk factors, then, I mean, that's huge, because that's one of the leading contributors to a bunch of types of death. Lots of death. So if we can reduce that, that's a pretty good thing, I think. So they give specific recommendations for how to start aerobic training program for older adults. Older adults being over 65. So they use the same guidelines, I'm sure, that you saw, Dan. But rather, a simple thing, sometimes we make things really, really complicated, but an easy recommendation that they gave was essentially the talk test. So start off your aerobic training, and just, if you can maintain a conversation, if you're not so winded that you can't have a conversation, well, then maybe you're training a little too hard. So start off at an intensity that your patient or your client or whatever can maintain a conversation, and then just progress from there. So a lot of the recommendations throughout this whole article were like that. It's like, look, we're dealing with a population that's essentially, I mean, think about it this way. If you, as you know, we're all in our 20s. So me, not for long, but you know, we're all there. And so the think about it this way. Like, I haven't played ice hockey competitively for, I don't know, like 5 years. If I tried to go play ice hockey right now, I would, it would not go well, you know, because I'm not conditioned for it. I'm under conditioned for it. So, I would need to slowly like get out there a couple times a week and just go for a gentle skate. I mean, we all know this. This is just progressive overload. This is just specific adaptation to imposed demand and overloading progressively, slowly, and all that. So that's all it is. Older folks, it's just that they've been out of training for a lot longer. So you need to be a little slower with integrating new exercise. It's not rocket science. So if old folks go out and get injured, yeah, well, no shit. It's because they probably, you know, went a little too hard, a little too fast, but it's not because they can't do it. Anyway, all right, next, resistance and strengthening. So resistance and strength training, strengthening and resistance exercise training has been a known effective method to counteract age-related changes of sarcopenia by improving muscle mass, strength, and function. They specifically recommend power training, so high velocity resistance training. The evidence shows that there is a high quality evidence that resistance training produces substantial increases in muscle strength and power in older adults. Obviously, there's some variation depending on, you know, individual factors. And again, these benefits are somewhat similar to the changes you'd expect from a younger client. So just because they're old doesn't mean that their cells don't still function in basically the same way that anybody's cells function. So they still adapt. And this can have improvements for chronic diseases. So this is interesting. Okay, let's see here. Reduce risk of osteoporotic bone fractures, reduce the risk of falling for people with osteoarthritis. High quality evidence regarding hip and knee osteoarthritis that we can reduce symptoms of pain, improve function and general quality of life. Start with low intensity and then just work your way up. And blah, 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 prevention of falls. So that's interesting, right? Like, we think that we got to go to balance exercises for fall prevention, but that's not necessarily true.
Well, I'm reminded of my grandfather, who is no longer with us, but I forget how old he was. He was in his 80s, and he was an active guy. He gardened every day. He had an orchard, and towards the end of his life, he did less of it, but he was very active. And he fell and broke his hip. That's kind of what led to kind of the spiral of him passing. But I'm reminded that he did a lot of aerobic. He did a lot of gardening. He was bending over, squatting, all these things, even late into his life. And so that requires a lot of balance. That is a balance activity in and of itself, and it's aerobic in and of itself. What I find interesting is if he had done maybe a little bit more strength training, added some weight to what he was doing, would it have maybe prevented him losing his balance and falling? I don't know, right? Like, it's an interesting question, because you're right. We are so focused on balance. And while it is important and it can train some of that intrinsic muscle control, is that what we should be looking at? It's a very interesting question indeed.
Mm-hmm. Next up was flexibility and stretching. Full disclosure, I have a very strong opinion about flexibility and stretching. And as a yoga teacher, it is not the bias that you might expect. I think that flexibility is fucking useless. Stretching is pointless. But that said, that's dealing with a person who's already got like a reasonable amount of flexibility. If you have jack shit for flexibility, then yeah, obviously you need to improve your flexibility. Especially when you think about like walking. If you're walking and you can't dorsiflex your ankle at all, or like you got 5 degrees of dorsiflexion, the chances of you kind of tripping on your own toes, that seems pretty freaking likely to me. So, the evidence of it, the evidence for flexibility wasn't really particularly strong to begin with. So I'm just trying to apply a little bit of logic here and say, well, yeah, maybe it matters if a person has no flexibility, but if they can dorsiflex their ankles, to a reasonable amount, and they can, they've got some hip internal and external rotation and, that kind of stuff. If they've got general, mobility, then it's probably fine. And we can work it, why, I think that giving older folks a flexibility training regime, it comes out of a mentality of fear. Like, oh, you can't give them a dumbbell, so let's just have them do some light stretches there. And it's just like, come on, they can do a lot more than that.
I wouldn't if I was, a lot of my clients are older, I would say the bulk of them, and I would not give them, I think stretching is kind of a waste of time because you have limited time, you have limited recovery ability as you get older, right? And it's not a huge gain for the time you're going to spend. Like, granted, if it's like your first week and you haven't exercised in 40 years, like maybe we'll just do some stretching because that stimulus might be enough to cause an adaptation, right? Like the whole point of exercise that's goal oriented is stimulus cause an adaptation, then you recover, or you have to stimulus, you recover, and then you adapt and you get better, and then you have to increase the stimulus and you kind of keep building like that. Mm-hmm. So maybe your first week would be some light stretching, but like ultimately you're going to progress past that load pretty quickly.
Right. Yeah, that's a good point. I mean, technically all tension, creates adaptability. But if we're also trying to get these individuals to have increased neural recruitment, there are motor unit recruitment, that kind of stuff, increased coordination, increased strength, those kinds of things that we know have all these other amazing benefits for them, then stretching is passive. It's just, again, a waste of time. I agree with the way that you put it, Blake. The next on this paper was stability and balance, and stability and balance. Oh, and one last comment on flexibility. Besides, we know that we can increase flexibility. If we need to increase flexibility, we know that strength training, especially eccentric training, is a very effective way of increasing flexibility anyway. And then you get all the awesome extra benefits of strength training. So I don't see the point. Why would you do passive stretching for flexibility when you could do something else that has all these extra benefits? So anyway,
it's not efficient, but I mean, you have to remember too that not all people do yoga for strength purposes. It's more mental health, right? So there's those benefits, right, that can come in as well.
Yeah, totally. So, I mean, as a yoga teacher, I mean, yoga has nothing to do with flexibility. Traditionally speaking, it's all about, mental awareness, calm breathing, awareness of yourself, self-reflection, those kinds of things. So I would just encourage meditation, honestly. Or if you want to use a movement practice, do one that's not just being a limp noodle, Anyway, all right. Let's move on. I also became aware of the Zoom limit, so we're gonna find out if Zoom actually kicks us off. It told me that it gave me a gift of free extra Zoom minutes, so we're gonna see.
Hopefully, according to the message I got. So,
let's. Ideally, we can keep this shorter. So I think we're getting a little. I'm getting a little long-winded, so I'm gonna hurry the hell up. So stability and balance. Is the thing I think that most people think of with older adults is, we got to improve their stability and balance. Let's do some of that stuff. The evidence for the benefits of specific balance training exercise is scarce. So there's not a lot of good evidence on this one, unfortunately, which is surprising to me. But there was, one study that they mentioned where Tai Chi helped decrease multiple fall risk. They do, weirdly enough, they bring up some balance training for myasthenia gravis and Parkinson's. So maybe doing some kind of balance training there, but it doesn't have to be like, get on a wobble board, just walking over difficult terrain, like walking over grass that's wobbly rather than concrete might help. One of the things I've heard other people suggest with balance training is that a wobble board is kind of a useless idea, because when are you on a ground that's actually unstable? Usually what it is that the ground has maybe variable composition, but it's not shaking. You're not, like trying to walk through an earthquake. So unstable loads might be more important than unstable surfaces.
And that last little bit, I interrupted too soon, my bad. But I think, though, too, if you're not ready for an unstable surface and you're not ready for that load on an unstable surface, then, falls are a perfect example of that. If you hit a little pebble or if you step off the edge of the curb incorrectly and you don't have the strength to catch yourself, thus you fall, right? So I think there is some benefit to wobble board and whatnot when it comes to training on an unstable surface, but you might be correct. It might be more unstable loads that are important for that adaptation to happen. But I don't know if I agree with you on that last little point.
Yeah, I don't know. I haven't read enough research on that. I've only heard opinions. So the last little bit here, benefits for cognition and quality of life. A physically active lifestyle promotes feelings of well-being and improved quality of life, and is associated with a lower risk of cognitive decline and dementia. An acute exposure to single bout of aerobic exercise can result in short-term improvements in memory, attention, and reaction time. Aerobic exercise plus resistive exercise training can produce improvements in anxiety, depression, and overall well-being and quality of life. Depression responded well to aerobic exercises conducted at 60 to 70% of maximal heart rate. I really like this last quote here because it starts by saying an acute exposure to a single bout of exercise has all these benefits. That's pretty cool to me, and I can relate to that because, man, when you get in a rut and you've been inactive for a long, long time, it feels like an impossible task to drum up the motivation to actually start doing something different, to change your life, to start a new habit, even if you know, like theoretically, that it's the most healthy thing to do. If your body's not on board, your body chemistry is not motivating you to do it, then all the knowledge in the world is not going to overcome your anxiety or your depression and get you out the door and going on a run. But if you are able to overcome it and just do it, that one time, even just one time you go out and you exercise, then it can have a huge impact on your overall physiology, state of mind, quality of, your mood and all these things. And then if your mood is on board, then maybe you're self-motivated from that point out. You're self-sustaining because you want more of that good feeling. So I think that that's really an important thing to keep in mind is like, the long-term success might come if we can find a way to get people to do something healthy, even just that one time. So that's really cool to me. Next is precautions and barriers. Really, the only thing that they mentioned with precautions and barriers was like, if you've got some major cardiovascular risk factors, then you want to take some extra precautions, but it's not an absolute contraindication. And just perform warm-ups and cool downs and gradually expose yourself to new stuff. So that's it. That's mine. Next.
Cool. All right. Just a few highlights. I kind of mentioned most of them earlier in my summary here quick, but a couple things that I left out from my initial summary was one, the increased risk of sarcopenia, which is just a decreased muscle strength and muscle mass. It's a term for both of those combined. In older adults, is upwards of 50% of that of a young adult. So by the time you reach your 60s, I'll just read it here. Most adults attain their peak muscle strength in their mid-20s and maintain this level of strength relatively well until the sixth decade. By the age of 80, strength declines on average to almost half that of a young adult. So this decline in strength is consistent across muscle groups and all types of measurements, isometric, concentric, eccentric, etc. And so really, really important point that as the older individuals age, they are more prone to decrease their protein synthesis. I mean, Blake's study pointed that out. Like within the first hour after exercise, there was more of that synthesis than with the older group. And so it's really important that we educate our patients that it's okay, right? That it's okay that this is a natural aging process, but we're doing our best then to reverse it. So I thought that was a really good point made by the paper. One really interesting thing from a diagnostic standpoint that this paper pointed out that is that, I lost it. Hold on. Okay, here we go. That they found that lower lymph strength is to be a stronger predictor of functional limitations than radiographic severity or knee pain, right? So often we pursue imaging, right? So you look at disc bulges in the low back with MRIs. Oh, we need to operate on that. Well, a good chunk of them aren't symptomatic, right? The patient isn't feeling anything. They're just there, right? Same with a lot of these OA patients. The only time they really know that they're having issues is if they're not functioning in the same way that they were before, if their strength is decreased. Even the knee pain isn't indicative of as much of a predictor of decreased function than of muscle strength. So I found that a very interesting statement made in the paper. As I said earlier, that the loss of muscle strength and mass is evidence towards direct contribution to OA. So we've already talked about that. Let me get towards the end here. The rest of it's pretty much just the statistics here. So in general, older adult population strength training has a very large effect on strength and a much smaller, barely significant effect on function. We talked about that earlier. So in general, strength it sees massive gains, but function in general, the range of motion, the ability to move, there isn't a huge difference except for those with OA, knee OA. So that's really an important thing to remember, is that with those who have OA, they're not moving the way that they could be moving, right? And then the strength is what's going to help them increase that movement. It's really, really important that we remember that. It's not just the strength that we're helping with these people who have these extra inflammatory issues or other functions. We're trying to get them to do the things that they want to do. It's not just about increasing strength. It's about increasing that function and giving them a good quality of life at the same time. So very important thing to remember. Lastly, clinicians should encourage participants in exercise training programs, even in the oldest of the old with OA. There's no evidence that there is significantly decreased efficacy or increased risk of adverse events with older adults with OA participating in exercise programs compared to younger adults. What Anthony was talking about earlier, don't be afraid. They're humans. They move. They're meant to move. Like they've been moving longer than most of us. They could probably do it better than most of us if we give them the chance to increase that strength and get rid of that sarcopenia. So yeah, that's basically what I had highlighted through this paper.
Awesome. I love that. That muscle, that strength is more predictive of, function and, all that stuff than radiographic findings. That's, got to keep emphasizing that, because people get really obsessed with this, disc bulges and stuff. And it's just not as important as you might think.
Agreed.
So I pretty much summarized everything I needed to the first time around, but I'm going to kind of merge what this paper found with some of the info that a group called Barbell Medicine puts out with Dr. Jordan Feigenbaum and Dr. Austin Baraki. They're two MDs and competitive powerlifters. So same kind of theme of sarcopenia, huge issue in the elderly population. If you don't have muscle mass and you don't have strength, you're probably going to fall more often. If you do fall, you're probably not going to be able to catch yourself. Just general quality of life is worse. Like a few of my clients, personal training clients, like they can't get up out of a chair without using their arms, and that's really frustrating to them. It's in addition to being kind of unsafe, it's kind of demeaning also, like not being able to just go about your daily life. So both of your papers talked about just like, we know that resistance training is good for elderly people. But I think that this paper, along with some of the material that Barbell Medicine puts out, and maybe we can link one of their things in our comments. I think that would be good. Kind of shed some nuance on how you go about training an older person. So like if you have a young, like 18 to 40, 50-year-old male, they're pretty responsive to resistance training. So like you might not need a huge stimulus or a ton of volume to get them to get stronger or bigger. It's kind of the same concept of like a healthy person with a good insulin response doesn't need a lot of insulin to like bring that blood glucose into the cells. But if you're a diabetic, you need a ton of insulin to have that exact same response. So I think this study shows that in younger people, you only probably need a certain amount of volume to get that protein synthesis response. But in those older populations, that same amount of volume at the same intensity did not have as big of a response. So my conclusion, and which would fall in line with Barbell Medicine's conclusion, is that elderly people should be training with more volume. Like you need more exposures to this resistance training stimulus. So maybe rather than training twice a week, like the physical activity guidelines say that you should strength train twice a week, you might want to have them do like 4 times a week. So you can increase that volume. Because as the paper also showed, increasing intensity doesn't really work. So like once you hit 60% of your 1 rep max, you didn't get higher muscle protein synthesis after that point. And also I would be very wary of having an elderly person, especially if they're not trained, do tons of work like up towards their 1 rep max.
Yeah.
Like if they've been lifting and training for, 5, 10, 20 years, like then that's fine. Like that's great. But if I had an elderly male or female come to me right now and they've been sedentary and they wanted to reverse their sarcopenia, I would slowly start them resistance training. But I think that more quickly than a younger person, we would have to increase how frequently they're doing this activity.
Cool. So the short takeaway that I'm hearing on that one is older folks train them more, not less. Which is kind of more, not less.
Opposite of what I think from my experience, like I don't think a lot of the trainers. I think people probably would say we should train with less because they're.
Hey Blake, just pause for a second. Hit your mute button and then hit it again. All right. Yep.
Okay. Yeah. So like from my experience, kind of in the bigger corporate gym, working in a bigger corporate gym, I'd say a lot of the trainers probably have the underlying bias that you should do less or give elderly people less difficult exercises.
Right.
But that's not true. You should give them the appropriate difficult exercise for their skill level, and maybe even bias yourself towards, instead of 3 sets of 5, maybe give them 5 sets of 5.
Right.
Like more stimulus.
Yeah, I think this is where I think a lot of people want a really easy road, and they don't want to really understand how to prescribe exercise. And it's just like, well, can old people do squats? I don't know. Which person? How much are they squatting? Are they squatting with weight? Are they squatting a front squat or back squat? Or like, what is their 1 rep max? You need to be able to find what their maximum, like what is the hardest thing that they can do, and then follow the guidelines and prescribe them exercise that is a specific percentage of that volume. I mean, you really have to understand more about exercise if you're going to prescribe exercise. Now, that doesn't mean that, like, if you're watching this and you're just older than 65 and you're just trying to get some guidelines for what you can do, that doesn't mean that you have to do all this math to get some benefits. Just go be active and realize that you're not fragile, and then maybe just follow the basic talk test if you're doing like cardio, and with strength, do something that feels manageable, and you'll probably be okay. But if you want to do better than that, because you're a trainer or a doctor of chiropractic or a doctor of physical therapy, you need to actually understand how to prescribe exercise.
And don't be afraid to progress people beyond, like, right. This is anecdotal based upon a lot of complaints of evidence-based doctors. But like a lot of chiropractors and physical therapists and physicians seem like really afraid to progress someone past like a dead bug. It's like a dead bug's not that hard. Like, it's not very fancy. Like, do a dead bug for a week and then have them stand up and start doing squats.
Yeah.
Like they don't, and like it might look a little wonky at first, but it doesn't need to be perfect. We know that perfectionism is correlated with higher risk of injury. Like it's
right.
Yeah.
Right.
You don't need to have the perfect squat, or be afraid that if you let your knees cave in a little bit, like your knees are going to explode, or if you let your back round a little bit, your back's going to explode. You just need to progressively overload the movement in a slow and like reasonable manner.
Yep.
Yeah. I want to mention though, like for those who are listening out there who are curious on how to help their patients with like increasing the load, it's okay to start light still. We're not saying just throw everything.
Oh, yeah. No, you have to start light.
I mean, in my paper, those at 10% of 1RM compared to 60% have the same benefits initially with their OA, right? Like you're still going to get some benefit, but don't be afraid, like Blake and Anthony are saying, don't be afraid to just get them up towards where they could be, right? Like it's good to start them small, but don't stay small.
Right. All the same things that we really, all of us, if you're, a student in some kind of rehab related field, or you're a doctor out in the field or whatever, like we should know basic stuff about how to progress an exercise program, about how to put together, rep schemes, and, how to overload. And I mean, just, add whatever, 10% load or volume a week, that kind of stuff, that we should know that stuff. And that doesn't go out the window just because they're, older than 65. All that stuff still applies.
Yeah.
And if you don't know, if you're like a student and you have literally no idea what any of this means, like that's okay. Like message us or leave a comment, and like there are plenty of resources.
Right.
Or if you want nothing to do with it, like find a good personal trainer and refer to a good personal trainer.
Mm-hmm.
Yeah, that's fair. I say we should know it because I feel like our school should be teaching it.
I agree.
But
not everyone wants to do it. Well, they're not workout junkies like us.
Yeah, I guess that's fair.
I mean, the physical activity guidelines are like,
Yeah.
what's it? I think like 3 hours of moderate activity or moderate cardiovascular activity. So like a brisk walk and 2 times resistance training a week. So like we should be able to responsibly prescribe that.
Yeah. Yeah. Physical activity guideline is 300 minutes per week of moderate intensity aerobic, and then 2 or more days a week in strength training.
Yeah.
So,
Cool.
So exactly what I just said.
Yeah. I was just reading the CDC website for you to make sure you were credible. Just like,
He's a live fact checker.
Yeah.
I really like that about people when they're fact checkers live on the air. All right, cool. Well, I think this is right at the point where we're going to fucking start totally digressing if we keep talking about this.
I think just in the video, put like in the comments, like if you just want the article stuff, stop after 5 minutes, and then we just talk about it.
yeah.
We summarized it.
Or make a little intro or something.
Well, anyway, I'm assuming that this is just one long stream, so let's just say that was a thing, and that's a wrap. And everybody, congratulations on being able to read. Thank you both for participating and regurgitating what you just learned. I think this has all been very informative. And thank you for our listeners at home, or, well, right now, everybody's at home, for joining us on this episode of Health or Hoax. Cheers.
See ya.